Good morning, everybody. We're going to give folks just a couple of seconds to trickle in, and then we'll get started. All right, maybe we can start with just a quick housekeeping and logistics reminders. This webinar is available both on your computer and also by telephone. Live captioning is available through Zoom. To enable that, you'll want to select the closed captioning icon on your toolbar to enable subtitles. American Sign Language is also available. You should see our wonderful ASL interpreter Cameo on your screen, and slides will be posted to the California Department of Aging's Hubs and Spokes Network for Aging and Disability webpage. We are saving time at the end for questions and comments, but I do encourage you to check out the Q&A icon on your toolbar. And as we're hearing presentations today, to drop in your questions as we go. And of course, we'll swing back around to those at the end. If you're joining us by Zoom, so you're on your computer, you can use that Q&A function that we talked about. You can also use the raise hand button to join a queue, and we'll unmute your line to hear from you directly. If you're joining us by phone, you'll want to press *9, and that will put you in the queue for us to unmute you. And at this time, I will pass it over to Dr. Carrie Graham.
Hi all, welcome. We want to welcome you today to this webinar on the Leadership and Aging webinar. And as you all probably know, this is part of an ongoing Aging and Disability Hub and Spoke conversation. The goal of this initiative is to build a strong aging network across California. And the purpose of these webinars is to sort of just bring opportunities to bring leaders and innovators to talk about innovations that are happening in California and across the country in terms of the aging network. If you missed last couple weeks ago, we had Professor Kate Wilbur from USC talking about measuring the success of the aging network, and that recording is available on the Aging and Disability Hub Spokes Initiative page. In early October, there'll be another great talk on promising practices, performance criteria, and excellence. That date is to be determined. But let's introduce our speaker for today. This is Amanda Brewster. And Amanda is an assistant professor of health policy and management at UC Berkeley School of Public Health. We're happy to have her today. Her research examines how management and interorganizational relationships influence the performance of healthcare organizations. And her recent work focuses on identifying effective strategies for healthcare and social services to work together to address both medical and social determinants of health, including studies of cross-sector collaboration at the community level, screening for social determinants of health and physician practices, and partnerships between AAAs and healthcare organizations. So I think we'll have links to this later. The Journal of Health Affairs has featured Dr. Brewster's works on linking AAAs with reduced healthcare spending and decreasing avoidable nursing home use. And she's also written on the crucial system of support that AAAs have played during the COVID pandemic. So I am going to hand it over to Amanda.
Thank you. Thanks, Carrie. It's great to see you and great to be here with all of you. So that was a very kind introduction. I will just add that I am based in a school of public health, and I focus on health policy and management. And I'm really excited to get a chance to speak with you all in the Aging Network, because one of my most interesting kind of research agendas has been understanding how important the AAAs in particular are in supporting health of older adults in their communities. So I'm thrilled to get a chance to share some of my work with you and also hear your impressions, because if there's one thing I've learned is that the Aging Network and folks, the aging professionals and service providers know a tremendous amount about the field that we're trying to study. And as you'll see, most of my data comes from talking to folks like yourselves. So we can go on to the next slide. So I'm going to be talking with you about partnerships between AAAs and healthcare organizations. And as a preliminary step, I always like to recognize my research partners. So this is work that I've been conducting over the past 5 or so years with a growing bubble of collaborators. So my team here at UC Berkeley works closely with the Scripps Gerontology Center at Miami University in Ohio, with some colleagues at Yale, with US Aging, previously called N4A, and we've received grant support for this research over the years from the Commonwealth Fund, as well as the Donahue Foundation and the RRF Foundation for Aging. So really kind of a large team behind the work that I'm going to share with you. So we can go to the next slide. Carrie kindly mentioned some of the articles that we've been publishing over the years as we try to build the evidence base to understand the important relationships across sectors, across the social care sector and across the healthcare sector, where we've really grown to appreciate the critical role that the Aging Network and area agencies on aging in particular are playing in that partnership work. You can go to the next slide. So today I'm going to actually share 3 different areas of research with you. So first, I'm going to tell you some stuff that you already know, I'm guessing, based on where you all sit. And that is some of the evidence on the role of AAAs in service networks for older adults, and the networks of healthcare and social service providers that support wellness for older adults in their communities. Because I think you probably know about that, I'm just going to spend a short amount of time on that. Then I'm going to move on to talking about the work that Carrie mentioned, where we've taken some national data sets and tried to see if we can track the financial and healthcare utilization impacts of healthcare organizations entering into partnerships with AAAs. So I'll tell you about that work. I will preview the results that we do find that we can track reductions in some types of healthcare costs and reductions in some types of avoidable healthcare utilization when we see AAAs entering into greater levels of partnership with healthcare organizations in their communities. And so there's more to it. There's some nuance that I'll get into, but that the top line finding is we are able to see at some regional levels, we are able to see some reductions in potentially avoidable healthcare use and spending when we see AAA partnerships and forming between AAAs and healthcare organizations. And then I will move on to some of my newest work with that group of colleagues, where we're trying to understand trends in financial contracts between AAAs and healthcare entities, understanding how those are unfolding, how those are trending across the country, and understanding what some of the facilitators are of those contractual relationships where AAAs are providing services for a fee to healthcare organizations in their local regions. So we can go on to the next slide. This is the part that I think you already know. So my work in this area began with an interest in understanding cross-sector relationships between healthcare providers and social service providers, which together support wellness and health for older adults in their communities. So my introduction to this work came from actually going out to 20 communities across the US and conducting a bunch of interviews with organizations in the healthcare sector and the social services sector to try to understand how they were working together to jointly support older adults, because we know that while important work takes place, important work to support health takes place in the healthcare centers, in hospitals, in physician's office, we also know that a lot of the critical determinants of health are actually shaped by what happens in people's lives outside of healthcare, well beyond before they come into contact with the healthcare system. So we were really curious about how this happens and how those organizations in the community work together to, as a kind of a net, support older adults in all the ways they need to be supported. So we did a lot of interviews, and then we did some network surveys to actually map how organizations across these sectors work together. And it may come as will come as no surprise to this audience that we're able to document that AAAs tend to be the organizations that really are the hubs in these cross-sector organizational networks and communities. And this is a network graph showing kind of the size of the bubble corresponds to the centrality of these different organizations in the network of healthcare and social service providers supporting older adults in their communities. And AAAs tend to be the biggest circle because they tend to be the hubs, kind of serving as connectors between the net of organizations that support older adults in their communities. We can go on to the next slide. And this is telling you the same thing. This is just showing you in a graph. I find it really satisfying to be able to see, look at this arrow, see AAAs at the top. There's the measure here is between the centrality, which is kind of a wonky measure, but it means the extent to which these types of organizations are serving as bridges between other sorts of service providers in their communities. And when we run the numbers, we see that AAAs across the country, this is looking at a national sample of AAAs across the country. In these communities, we were able to look at AAAs are far and away serving as kind of the greatest sort of hub type of role in the networks of cross-sector organizations that support older adults. So we can go on to the next slide. And I will actually pause. So I should have said this in the beginning, but I told you I'm going to talk about 3 different topics. I'm also happy to pause if you have questions. I'll just take a quick pause after each of these topics to check if anyone had questions. And then again, I'll pause at the end because I am really curious to hear your feedback and questions and kind of how you see you all who are joining the webinar actually see some of these issues in a way that I might not. So let me pause and ask Carrie if there are any questions at this point.
No, I don't see anything in the Q&A box, and I don't see any hands raised at this point, but I will be continuing to monitor that. So be sure to put, a question anytime in the Q&A box or raise your hand.
Okay, thank you. Yeah, I surprised you all with that. But now when I'm done talking about the impacts on healthcare use of spending, I'll take a pause and I'm happy to answer questions right away in case you have any. So being aware kind of after this foundational work where we are able to really illustrate that critical kind of hub role that AAAs play in the centers of their community networks of healthcare and social service organizations supporting older adults. Our team moved on to try to understand if we could track the impacts of partnerships between healthcare organizations and AAAs on healthcare utilization and spending. And so we've just kind of finished a stream of research looking at whether changes in AAA partnerships were associated with changes in 3 county level measures of potentially avoidable healthcare spending or utilization. And those county level measures that we look at are Medicare spending per beneficiary, the level of avoidable nursing home use. So that we measure that by looking at the totality of nursing home residents in a county and identifying the proportion of those residents that are identified as having low care needs, so suggesting that those are residents that could potentially be cared for in the community if they had enough supports around them. And then third, we look at the hospital readmissions rates. Now we can go to the next slide. And the way we're able to look at this is thanks to many of you who who've completed the National Survey of Area Agencies on Aging over the years. So my team works closely, as I mentioned, with the Scripps Gerontology Center at Miami University, as well as US Aging, which was until recently N4A. And we've been able to take advantage of this tremendous data resource that you all have been contributing to over the years to understand how partnerships have changed over time. So we have been able to use 4 survey waves at this point from 2008 to 2016, and there have been a few further waves of the survey since then. So what we've been able to do is, for some of you who may have completed the survey, might remember that you actually have reported on partnerships with different healthcare entities over time, and we can look at the change in reporting partnerships with healthcare and see if that corresponds with a reduction in these measures of potentially avoidable healthcare spending and potentially avoidable utilization. So that's how we've been able to set up this study design to look at the impact of increased partnerships and see if that corresponds with decreased levels of healthcare utilization or spending. So we can go to the next slide. And this is a graphic showing the change over time. So we published some results of this study in Health Affairs last year in 2020, really speaking to the health policy and healthcare sector audience. And they prepared this lovely infographic for us, showing that what I think probably many of you will be aware of, that there is a trend towards increased partnerships between AAAs and specific healthcare organizations in their communities. We can see this is particularly pronounced with partnerships with hospitals nationally. We can see increasing proportions of AAAs reporting partnerships with hospitals, increasing proportions of AAAs reporting partnerships with mental health organizations, and increased partnerships with Medicaid and managed care organizations, as well as geriatricians, Indian Health Services, and SHIP providers. So pretty much across the board, most of the healthcare organizations that are measured in the survey, we see trends towards increasing partnerships between AAAs and these various healthcare organizations.
Hey, Amanda, can I interrupt you with a question that I think fits here from Tatiana Fassieux? Have you considered the impact of healthcare spending on counties where there are no Medicare Advantage plans? Or
such an important question. So we have some limitations in our methods, but we are aware that our measures of healthcare spending come from fee-for-service Medicare, and the trend towards increased coverage by Medicare Advantage makes that an important thing to consider. So the way we adjust for that is in the models we use to look at change over time, we also account for change in Medicare Advantage penetration over time as a way to account for the trends towards Medicare Advantage coverage in the same period where we're seeing trends towards increased partnerships.
Thanks, Amanda. And I also just want a note on accessibility, making sure we're speaking slowly so that the ASL interpreters can keep
Thank
up.
you. I saw that in the chat. Yeah, I have so much to say that sometimes I say it too quickly. So thank you. I'll try to slow down a bit. So let me tell you about our results. The fact that we see change over time in formation of the partnerships between AAAs and healthcare organizations allows us to see if that corresponds with change over time in these measures of healthcare utilization and spending. And we find that when we see increased partnerships with hospitals, that's associated with significantly reduced Medicare spending per beneficiary in the counties within AAA's planning and service area. So we see that adding a hospital partnership is on average associated with a reduction in spending per Medicare beneficiary of $136 per beneficiary, and that's statistically significant. Additionally, we see that when AAAs form partnerships with mental health organizations in their communities, that is associated on average with a reduction in low care nursing home use in the counties covered by the AAA of 0.5 percentage points, which is again a statistically significant difference. And I'll note that this is asking, like, when we're looking at county level measures of spending and utilization, and so we think the way to look at this is probably as a lower bound, as kind of the least impact that we could possibly be seeing, because in reality, we are not only looking at older adults or Medicare beneficiaries that are actually receiving services from AAAs or actually benefiting from these partnerships. We're looking at all older adults in the county. So we would hypothesize that for the older adults that are actually getting services and are closer to this action, that we would be seeing a bigger benefit, a bigger reduction in potentially avoidable spending or utilization, because they are the ones actually receiving the services. And then the other piece of evidence that we've been able to look at here in trying to understand the impact on partnerships between healthcare organizations and AAAs is looking at the formation of livable community initiatives over time as another measure of the level of partnerships across sectors in communities. So that's another area where we've seen significant associations between the formation of funded livable community initiatives and reduced low care nursing home use in the counties covered by AAA. So we, you all have, many of you who complete the national survey have reported over the years on participation in livable community initiatives and the availability of funding to support that participation. And so we've been able to look at when livable community initiatives are established, with funding, we can look at the impact on low care nursing home use, and that's where we see the fall in low care nursing home use corresponding with the establishment of funded livable community initiatives. And we take this to mean that we might be seeing more advanced collaborative capacity to bridge the healthcare and social care and aging network capacity at the community level, and that could be contributing to better supports for people to age in place if they want to. So we can go to the next slide. And let me pause after that section to see if there's any questions on that topic of impacts of AAA partnerships on potentially avoidable healthcare spending and utilization.
There was one follow-up question in the chat about partnerships with ACOs.
Let me see. So your interest in partnerships with ACOs specifically? Yeah, you know what? I'm going to tell you about partnerships with ACOs. They were not collected on that first partnership survey, but since then, starting in 2017, there has been an additional survey focused specifically on contracting. So AAAs providing services under contract with healthcare entities. And in that survey, we do measure ACOs, and we are able to see specifically the breakdown of partnerships with ACOs. Does that answer the question?
I think so. Why don't we go now to Ronald Lee? We can unmute you, your hands up, so you can ask your question directly.
Hello, Dr. Brewster. Thank you for taking my question. I was just curious what kinds of control factors you were using, like in terms of rural versus urban, income levels, language or ethnicity, and other types of services that might not be administered directly by the AAA, such as in-home support services or adult protective services.
Super question. That's a great question. So that is often a challenge when we try to compare different locations. So figuring out how to adjust for the different environments where AAAs are working, the different county level environmental influences on older adults. And that can be a really real challenge, which is why we were so thrilled to be able to look at change over time, because what we actually did for that analysis that I just told you about is we used counties as their own controls. So we were not comparing, say, one county with another county. We were comparing one county in 2008 to that same county in 2010 to the same county in 2013. So that was a way we got around having to worry about differences within the county influencing this. And the only thing that we think about, and that's sort of a study design where we're looking longitudinally at whether within the county, the AAA serving the county has added partnerships, and whether within the county, utilization of healthcare has changed over time. The only sorts of controls we need to put in are things that change over time. And we, some of many of the critical things don't change too much over time. Some do, and so we did introduce those as controls. So we wanted to adjust for the fact that, as I mentioned, Medicare Advantage penetration can change over time. So we adjusted for that, and we adjusted for some socioeconomic characteristics that might have changed over time. So things like income level, average income level of the county, and what else? I think that was pretty much it. We were pretty parsimonious about the things that we adjusted for because we felt pretty comfortable with the comparison of counties to themselves over time. And the great example that you pointed out about the differences between rural counties and urban counties, which we know are pretty substantial when we think about opportunities for partnership. Those are characteristics that we didn't need to adjust for because we were only comparing a rural county to itself in previous years or an urban county to itself in previous years.
Amanda, can I just quickly ask from the Q&A of the AAAs with health partnerships that you looked at, what % were county-based AAAs?
Oh yes, I can tell you the exact level. So when we look nationally, different states, of course, have very different county level governance administrative structures. When we look nationally, we do find that AAAs located in county governments tend on average nationally to be doing a bit less in the way of partnering with healthcare, whereas AAAs that are structured as standalone nonprofit organizations tend to be doing a bit more in the way of partnering with healthcare entities. And so nationally, that's the trend that we tend to see. But within specific states, so like, for example, the county level administrative structures we have in California are quite different from some other states where the counties don't play such a big role in service provision. So the general trend is less partnership in county or local government local government kind of collaborative organizations. Any other questions?
I don't see any other questions, so let's just continue.
All right, and I'm going to tell you a little bit more. We also take a look at the differences between county-based and non-county based AAAs when we take a look at the contracting survey results. Okay, so I'm going to move on to the third topic where we're focusing in on contracting with healthcare. And let's go back just one slide. I'm going to tell you about these graphs before I get into the further a bit further into this area. So this portfolio of work is taking advantage of a set of surveys called a request for information set of surveys that were facilitated by Miami University, by the Scripps Gerontology Center, as well as N4A and ACL, to really hone in on emerging contractual relationships between AAAs and healthcare entities in their communities. And this survey was administered in 2017, 2018, and again in 2019 or 2020, but we're just looking at the 2017, 2018 results. For most of the analyses I'm going to be telling you about, with the exception of these graphs, which I want to show you because we know that there is a steady increase in contracting between AAAs, CILs, and other CBOs over time. The request for information did go out to AAAs, but it also went out to Centers for Independent Living and a few other categories of CBOs. And you can see in these graphs that come from a great kind of research brief put out by the team at the Scripps Gerontology Center, that over the years, even within that brief period between 2017, 2018, and 2020, the proportion of the CBOs that reported contracting with any healthcare entities in their areas steadily increased, going from about 38% in 2017 all the way up to about 44% in 2020, which is a statistically significant increase even within that brief period of time. We also see a steady increase in the proportion of CBOs that are contracting as part of a network. So contracting networks are appearing to be pretty significant parts of this story in supporting this sort of activity. So as I mentioned, this includes AAAs, also includes the other types of CBOs that reported to this survey. And if you go to the next slide, this breaks it down specifically by for the AAAs that reported their contracting behavior on the survey. And this is looking at reports in 2017 or 2018. And we're able to look at about 330 AAAs. And then again, this is from the entire United States. And we can see here we do have, to the question before, we are able to look specifically at accountable care organizations, hospitals, primary care, long-term care, as well as health insurers. And so this graph shows you that the most common type of partnerships that AAAs have reported in this period of time were with a hospital or health system. That's just about 25% of AAAs reporting a partnership with either a hospital or health system. And then on the insurer side, we see that just over 15% of AAAs were reporting a partnership with a Medicaid managed care organization. That was the most common type of insurer. And we are thinking that it's important to think in a nuanced way about what types of healthcare entities are partnering with AAAs, because those contracting relationships and kind of the incentives are going to be a bit different depending on whether we're thinking about healthcare delivery organizations, providers, versus health insurers or payers. The other thing I'll tell you about, which again, for this audience, you may probably already know, is that we also ask about the services that AAAs provide in their contracts with healthcare entities. And the most common services are case management, care transition planning, assessments for long-term care, health education, nutrition, transportation, and the list goes on to cover quite a diverse range of services, but the most common services are case management or care transition planning.
Amanda, can I interrupt you for a second?
Yes, please.
We do have a question asking if you've evaluated the increase of AAA healthcare contracts and whether that's increased client satisfaction.
I would love to evaluate that. So we don't have the data available at this point to be able to look at that, but I think that needs to be the next frontier. And I will tell you, just as a big picture, what we've been able to do in the research agenda I'm talking about with you today is compare AAAs to other AAAs across the country to try if we can find some patterns that are generalizable at the big picture planning and service area level. And that's important and can help with kind of some big picture policy recommendations and generation of evidence. But I think we really need to be able to get into the level that you're mentioning, where we're able to identify individual beneficiaries of these partnerships and track patient satisfaction, as well as the variety of other health outcomes and wellness outcomes that we anticipate are going to come out of these relationships and these contracts. The data on that are a bit harder to come by, or are kind of the next frontier. So we don't have that yet, but I love that question because I think that's a critical area for further research, and I'd love to do that research if you have the outcomes. Any other questions at this point?
Nope. Let's keep going.
Okay. All right, let's go to the next slide. So what we do have data to look at now is whether contracts are in place, whether AAAs report contracts with healthcare entities, and we have data to be able to look at the environment of the kind of health policy landscape and healthcare provider landscape in the counties the AAA serves. And we're also able to look at characteristics of the AAAs that we get from those rich surveys that we've collected over time that you all have, many of you have filled out over time. And we wanted to take a look at this because, you know, we need to think about two sides of this coin when we try to understand whether AAAs are entering into contracts with healthcare. We need to understand how AAAs that are interested in developing contracts might build their own capabilities to enter into those partnerships. And we also need to understand what incentivizes healthcare organizations in their regions to reach out to AAAs and other community-based organizations, and what influences the incentives for healthcare organizations to want to start directing funding resources to community-based organizations. And we think that these can be influenced by pretty different policy environments and pretty different market environments. And the first round of research we've done is looking at how characteristics of the healthcare market, the state policy environment influencing the decisions of healthcare organizations, and how the characteristics of AAAs influence whether we're seeing contracts form between AAAs and specific types of healthcare entities. So we can go on to the next slide. And this busy slide, this busy table is giving you our results. So what we've done is we've kind of dichotomized the outcome of contracts, because we thought that, and initial looks at the data suggested that contracting with healthcare delivery organizations like hospitals or clinics or primary care organizations or ACOs might be driven by different sorts of factors compared with contracting with insurers, both in terms of what the healthcare market and policy environment is encouraging these healthcare entities to do, and also what capabilities AAAs might need to develop in order to enter into these contracts. So we thought these were likely to be kind of facilitated by different patterns of environmental and organizational characteristics. So we looked at them separately. And what we find is that we do see different features shaping whether contracts are forming with healthcare delivery organizations and AAAs, as opposed to looking at what is facilitating contracts between insurers and AAAs. So I'll go through this slide and kind of explain what these results mean. So the first result has to do with organizational structure, and to the question earlier about the difference between AAAs that are structured as independent nonprofits versus part of local governments or councils of governments. We do see that on a national level, AAAs that are structured as independent NGOs are significantly more likely to enter into a contract with either a healthcare organization, a healthcare delivery organization, or an insurer. So AAAs that are structured as part of a local government, on average nationally, are a bit less likely to enter into these contracts. We also see, if you go down to the next row, we're looking at the differences between urban and suburban AAAs and rural AAAs. And we see, again, there's some systematic differences nationally, where AAAs that are serving a predominantly urban and suburban population are more likely to enter into contracts with healthcare delivery organizations as compared to AAAs that are serving rural populations predominantly. So that's something that we can't change, the area served, but it's important to recognize that that's the environment. Then we looked at 4 other factors that I want to highlight. One is a business capability scale, and you'll probably be wondering what's on that scale. I'm going to tell you on the next slide, but I'm not going to go there quite yet. I'm just going to tell you that in the surveys of AAAs, we've we've been able to collect data on a battery of different activities that AAAs have explored or kind of developed over the years that are directly relevant to contracting, to building business capabilities that could facilitate contracting with healthcare entities. And so we take an average of those different activities and we generate a score to just kind of indicate where the AAA is where the AAA has kind of gone in implementing these different types of business capabilities. And there we see two things that I think are really important and interesting. One is that the scores on this business capability scale are super predictive of having a contract with an insurer. So the right column shows that the odds of having a contract with an insurer are over 6 times higher for AAAs that are scoring in the top quartile. So that's like the top 25% versus the AAAs that are scoring in the bottom quartile, the lower 25%. So that seems to be built kind of adding these different business capabilities seems to be very highly correlated with entering into contracts with insurers. When we look at the column on healthcare delivery organizations, we see there's a trend towards, when AAAs are reporting contracts with healthcare delivery organizations, they're reporting a bit, this is somewhat correlated with these business capabilities, with layering on these different business capabilities, but the relationship is not as strong. It's not significant. It's not statistically significant even, although you can see that there is a trend where AAA is in that top quartile, the highest, the most business capabilities that they've layered on. They do have odds of, about twice the odds of having a contract with a healthcare delivery organization, but there's a bit of noise in there and it's not statistically significant. So we don't emphasize that result. So that's, I think, an important point, both that we see different patterns between what's driving or facilitating or associated with contracts between AAAs and insurers and AAAs and healthcare organizations, delivery organizations. And also that this business capabilities kind of scale or layering on is significantly associated with contracting with insurers. The other question that is very highly predictive of having a contract with an insurer is whether other AAAs in the state contract as part of a CBO network. So that's getting to this question of what roles these CBO networks are playing in facilitating contracting with healthcare entities. So what we're seeing here is that AAAs that have access to a contracting network, and we're getting the signal that they have access to that if somebody else in their state has reported contracting as part of a CBO network. We're finding that that's very predictive of having a contract with a health insurer. So the odds are about 5 times higher for AAAs that are in a state where other CBOs have reported a contracting network. But we're seeing again that that's not something that's so prominent in predicting contracts with healthcare delivery organizations. So those are the things, those two kind of the business capability scale and having a CBO contracting network in your state are the things that we're seeing very highly predictive of contracting with insurers.
Amanda, can I interrupt real quick with a question?
Yeah, please do.
We probably want to get to the whole Q&A.
Yeah, this is my last slide, so we'll do that.
But we have a question that since California AAAs have the high cap ship grant, what types of precautions are or should be in place so as not to steer Medicare beneficiaries into plans that may not be appropriate for their healthcare needs?
So that is a great question. I think that I'm probably not the best person to answer that. I mean, I'm really glad to hear like that awareness and like thinking about cautions there. I think we unfortunately don't have data that I've been able to analyze that gives us some specifics on what we can do to head off that risk. Any other questions at this point?
Nope.
Okay, well, let me tell you about the two things that are highly predictive of having contracts with healthcare delivery organizations. Those are having, so actually the opposite. We're finding that if a state has managed long-term services and supports, we're seeing that it's less likely AAAs report contracts with healthcare delivery organizations. And if AAAs are located in a state that has implemented a lot of the delivery system reforms to promote integrated healthcare, we're seeing that the likelihood of having a contract between AAAs and healthcare organizations is much higher. So when we look at states that have implemented 4 or 5 state delivery system reforms to promote integrated healthcare, and these are things like the Health Homes program, like the Medicaid 1115 waivers for delivery system reform, that those states that have done the most in that area are the states where healthcare organizations and AAAs are most likely to have contracts with each other. We can move into the next slide. This is, I think, the last one. And the next slide kind of gives you the big picture of what I just told you, that healthcare delivery organizations are and AAAs are most likely to have contracts if their states have adopted a lot of delivery system reforms for integrated care. And if the states do not have managed long-term services and supports. So we're seeing kind of those delivery organization contracts primarily predicted by what's happening in the state level policy environment for healthcare organizations for the most part. On the other hand, when we look at contracts with insurers, we're seeing that those are quite sensitive to AAA's level of business capabilities and the availability of a state CBO network that contracts together. And I think the next slide is the last one, if I'm remembering correctly. And this is to answer the question that you might have about what's in that business capability scale. It's a combination of these services that are listed in the table here. So whether the AAA has been developing a legal structure like a 501c3 to enter into contracts, doing some kind of business development work like competitor analysis, market analysis, business plans, expanding capacity to operate, enhancing IT infrastructure. So these are all things that go into that scale, and it just kind of registers the number of these that the AAA has layered on up to the point that they answered the survey. So I think this is it. If you go to the next slide, this is just kind of what I already told you, that policies need to think about what's happening in the healthcare environment, what's prompting healthcare organizations to reach out to AAAs and enter into contracts, as well as what's supporting AAAs to be able to do these contracts if they want to. And highlighting the distinction between what's driving contracting with delivery organizations versus health insurers. And then after this, I think you should see the last slide, which gives you my email address. Thanks very much for your questions so far. And I'm hoping that we can field some more questions with the rest of our time.
So we have about 7 or 10 minutes, and I just really want to encourage you. And just to say thank you, Amanda. This is, it's not that often that you can find someone doing such research that speaks so well and so appropriate for what this initiative that's going on in California. So really want to open it up to all of you. I know Amanda would love to hear from you. So raise your hand, click the little hand button on the bottom bar, or type an answer, a question in Q&A. And to get us started, we have Haley Gallo asked, do you know how much is based on AAA's adopting changes the state encourages versus how much technical support states provide to support partnerships and contracting?
That's such a great question, and we can't disentangle them, but I think it's reasonable to expect that both of those both of those factors are coming into play, that kind of what states are doing. And part of what states may be doing is helping to seed these CBO networks. So we see that CBO networks were highly predictive of contracting with insurers. And that's something that states could be doing. Our challenge in looking at this national scale data is we're looking across all the states. So we know that different policies are coming into place in different ways in different states. But because we are just comparing at the AAA level, we can't really look in too great depth inside what's happening in given states because we've only got 50 of them. And when we look at the aging network, we actually only, in kind of predictors of what's happening with AAAs, we only have 42, the 42 states that organize their aging network in AAAs. So it's a great question though, and I think both of those factors are coming into play.
Anybody else have a question? You want to raise your hand or type it into the Q&A? I have a question, Amanda. Oh wait, Tatiana. Let's let Tatiana ask.
Thank you for acknowledging me. I work for both the local SHIP and also an advocacy organization, California Health Advocates. The area of contracting is very, very concerning to me because I was the one that had mentioned the leading, because there's so much fraud right now happening in the steering of Medicare beneficiaries into plans that may not be appropriate. However, I'm looking at the AAA in California is usually their contracts are a July through June contract, okay? Whereas with Medicare Advantage plan is a calendar year. So there are potentially issues dealing with plans going away when a AAA has had a contract with them. And so agreements have to be flexible to be cognizant of this landscape that changes every year.
Mm. Yeah, thank you. That's a fantastic point. And I'll use that opportunity to highlight that what we have learned, kind of what we've taken away from this research, is in part the pieces of data that I've shown you and kind of those analyses I've shown you. We've also taken away that this is an extremely complex type of process that we need to understand in greater depth on the ground. And so the work that our team is actually conducting right now is interview-based work where we've just finished about 150 interviews with AAAs across the country and partners across the country in the healthcare sector to try to understand what some of these in-depth issues that you're raising about kind of what the challenges can be on the ground and the extent to which organizations have found ways to overcome those challenges, or the extent to which they're still worried that those are going to be roadblocks.
Thank you.
Any other questions? I'll ask my question, Amanda. I'm interested in if you have any more thoughts around why AAAs are less likely to contract with healthcare delivery organizations in states that do not have MLTSS.
Yeah, that's a good question. So what we are hypothesizing is that in states that have MLTSS, those managed care organizations are actually doing some of the work that otherwise might be contracted out to AAAs. That's our hypothesis now. We can't definitively answer that question, but that's our hypothesis. In talking with AAAs in some other states, that has been kind of that's what they've told us, that they think that the dynamic is that sometimes when there is MLTSS, that work doesn't come out to AAAs in the same way.
Yeah, that's a really interesting finding. Anybody else want to raise their hand for a question for Dr. Brewster, or put a question in the Q&A and I will read it. I know she wants to hear from you in terms of maybe how you interpret these results or what you think was interesting about these results. Last couple minutes to ask a question or raise a thought. All right. Well, if we don't have any more questions, I do want to remind you that there is we'll be having another webinar in early October with the date to be determined, called Promising Practices, Performance Criteria and Excellence, with leadership from USA Aging, formerly the National Association of Area Agencies on Aging, and the Association on Aging in New York. So that should be very interesting. Please be looking out for an early October date for that. Oh, I see one more question. Christina asked, the AAA structure is more than likely going to be changing in California to be within county and not nonprofits. As the state moves in this direction, what should we at the county entities consider in order to be more collaborative with healthcare organizations? Like that question.
Yeah, that's such a great question. So this is where, so thinking about California and the strength of the county administrations, I think that's where some of the national level data is probably not going to apply exactly in California in exactly the same way. So what we have learned from this work, though, is that the state delivery system reforms that are encouraging healthcare organizations to contract are important. So that's not something that the county entities are necessarily in the driver's seat for, but may be able to kind of remind their stakeholders about. And then the other thing that we've seen is that when we have seen these business capabilities are highly predictive of contract formation. So there are a number of learning collaboratives and initiatives that have been run at different levels of geography to try to help AAAs with kind of building these business supports. So I would say that is an area where county entities and AAAs could take a look at how to build those types of capabilities and think about those capabilities as something that do seem to foster collaboration with healthcare organizations, particularly on the insurance side. But we also see signals that those sorts of investments that are hard, like I want to acknowledge that building those capacities and capabilities takes investments over the course of years, but that those do seem to trend with formation of partnerships and contracts with healthcare entities, so that investment does seem like it may be paying off for AAAs that are doing that work. And Carrie, I think that you are muted, but
sorry,
I see that you're probably.
I just want to say we're at time. I want to thank Dr. Amanda Brewster from UC Berkeley for being here and sharing her research today. Thank the ASL interpreters. Thanks CDA for hosting this, and thanks to all of you. And we will see you in October for the next webinar.
Thank you.